Hey everyone, today we're going to jump right in and tackle one of the most complex and honestly one of the most common conditions we manage in pharmacy practice, dementia. We're going to cover the absolute essentials, from the different types all the way to deprescribing, and we're going to do it all through the lens of a pharmacist.
Okay, so let's picture this, because I know we've all been there. A worried caregiver comes up to your counter. They've heard about some new drug for memory loss, and they're looking to you for answers. They need clear, safe guidance. This whole explainer is designed to give you the clinical toolkit you need to answer those questions confidently and help them manage their loved one's care.
So, here's our game plan. First, we'll start with a quick clinical primer on what dementia actually is. Then, we'll put on our detective hats and investigate drug-induced causes. After that, we'll dive deep into the core medications, talk about managing those really tough responsive behaviors, and finally, we'll wrap up with the crucial skills of counseling and deprescribing.
All right, let's get started with Section 1, a clinical primer. We've got to understand the landscape before we can navigate it.
So first things first, what are we actually talking about? Dementia isn't just one disease, it's a syndrome. And the absolute key phrase here is that it interferes with normal activities. This is so much more than just age-related forgetfulness or misplacing your keys. It's a decline that impacts daily life, and critically, it's progressive. Our goal here is management, not a cure.
Now, if you look at this table, you can really see how the underlying cause, the pathophysiology, directly drives the symptoms we see. With Alzheimer's, it's that classic, slow, gradual memory loss. But look at vascular dementia. It's often a stepwise drop, where things get noticeably worse after something like a stroke. Lewy body's really distinct with those early visual hallucinations. And then you have frontotemporal, which can show up first as shocking personality changes. Knowing these differences helps us understand what caregivers are actually telling us.
Okay, Section 2. This is where we as pharmacists shine. It's our investigation. Before we even think about adding a new drug, our very first job is to hunt for any medications that might be making things worse.
And here they are. These are the usual suspects. Our high alert list for any medication review in an older adult, especially one with cognitive issues. We have to be screening for these. We're talking about old-school antidepressants like amitriptyline, bladder meds like oxybutynin, and this is a big one, over-the-counter antihistamines like diphenhydramine. Every single one adds to that total anticholinergic burden.
And let me be really clear, this is not just about managing some reversible brain fog. The stakes are so much higher. The evidence is solid on this. A higher anticholinergic burden isn't just linked to confusion, it's associated with increased mortality, period. Finding and deprescribing these drugs is one of the single most important safety interventions we can make.
All right, Section 3. Now that we've done our investigation, let's talk about the drugs we actually use to treat the cognitive symptoms of dementia.
The real workhorses of dementia therapy are the cholinesterase inhibitors. They work by boosting acetylcholine levels in the brain. They're the go-to for Alzheimer's, and you'll also see them used for vascular and Lewy body dementia. But just as important is knowing where not to use them. For frontotemporal dementia, they can actually make agitation worse, so that's a key clinical pearl to remember.
So how do we pick between them? Well, let's break it down. Donepezil is the only one indicated for all stages of Alzheimer's, and that super long 70-hour half-life makes the once-a-day dosing great for adherence. But remember, that also means side effects will stick around longer. On the other hand, rivastigmine has a really short half-life, which can be great if someone's sensitive to side effects. Plus, it has that patch, which is fantastic for bypassing the gut and reducing GI upset. Speaking of side effects, this slide is basically your counseling cheat sheet. The GI stuff is, by far, the most common. You have to warn caregivers about nausea, diarrhea, and potential weight loss. Neurologically, vivid dreams are a big one that people often don't expect. And while it's uncommon, you absolutely have to be aware of the potential for cardiac effects, like a slowed heart rate, especially in patients who already have heart issues.
So let's turn this into actionable advice. Number 1, start low, go slow. Titrating up every 4 weeks is the standard to help the body adjust. Number 2, and this is so important for us as pharmacists, we have to prevent the prescribing cascade. If a patient gets urinary frequency from donepezil, the answer is not to add an anticholinergic like oxybutynin. You're just fighting yourself. The right move is to lower the dose or switch the agent.
So who's the other major player in our toolkit? That would be memantine. It works on a totally different pathway, targeting glutamate. You'll typically see it come into play later on, for moderate to severe Alzheimer's. It's often added on top of a cholinesterase inhibitor or used by itself if those first-line drugs just aren't tolerated. Okay, section 4. We're now moving into what can be the most difficult part of dementia care, managing responsive behaviors. This is where we have to be extremely careful with high-risk therapies.
Before we say single drug name, I want everyone to just look at this number. 1.6. That's the increased risk of death associated with using second-generation antipsychotics in elderly patients with dementia. This isn't a small risk. This is a black box warning. It fundamentally changes our entire risk-benefit conversation, and it's why these drugs must always be the absolute last resort.
So, if we absolutely have to go there, what's our safety checklist? First, the indication has to be severe. We're talking aggression or psychosis that puts someone at risk of harm. We start with a second-gen agent like risperidone, and we live by the start low, go slow mantra. Critically, the goal is improvement, not getting rid of the symptom completely. And we have to be monitoring constantly, with a mandatory check-in every 3 to 6 months to ask, do we still need this?
So what about alternatives? What else is in the toolbox? Well, you're going to see trazodone used off-label a lot, especially for things like agitation or that classic sundowning, where sleep cycles get all mixed up. There's some decent evidence that it helps with sleep time, and it generally has a better safety profile than antipsychotics or benzos, making it a reasonable option to think about.
And that brings us to our final section, counseling and deprescribing. We've talked about starting meds, now let's talk about how to stop them safely and effectively.
So, when is it time to have that conversation about stopping a drug like a cholinesterase inhibitor? This slide gives us some really clear triggers. It might be as simple as the patient or caregiver deciding they're done, or maybe we're just not seeing any real benefit anymore. Intolerable side effects are another big one, and importantly, as the illness progresses into the severe or terminal stages, the focus shifts, and stopping the medication is often the most appropriate part of providing good palliative care.
Okay, so how do we actually do it? The number one rule is you never ever stop these drugs cold turkey. It has to be a slow taper. A good rule of thumb is to cut the dose in half or go to the next lowest strength, and then wait a full 4 weeks before the next reduction. During that whole time, we and the caregiver have to be on high alert for withdrawal, which can look just like the dementia getting worse. If there's a major decline, the right move is to go right back up to the last dose that was working.
You know, when you boil it all down, our vital role in dementia management really comes back to these 4 fundamental questions for every single drug on a patient's profile. Does it have a clear indication? Is it actually working? Is it as safe as it can possibly be? And can the patient physically take it? That framework is the heart of medication optimization.
So I'll leave you with this final thought. After all this, what is one single concrete change you can make in your practice tomorrow? Maybe it's flagging every patient on your list who's on oxybutynin for review. Or maybe it's making a little counseling checklist for the next time you dispense donepezil. The goal is to turn this knowledge into action that makes a real difference for the patients we care for. Thanks so much for joining me.